Hello everybody. This section will be about some antimicrobials that don't really fit into the other classes. This section was originally presented by Emily Stewart, who is currently an infectious disease pharmacist at Cone Health. However, this will currently be presented by Austin Pates, a PGY1 acute care pharmacy resident, and will be completed by Nathan Wise, another PGY1 acute care pharmacy resident. Nitrofurantoin is a drug that goes by the trade names Macrodantin or Macrobid. As you can tell by the name Macrobid, it is dosed 100 mg PO BID. Macrodantin may be dosed up to 4 times a day with 50 to 100 mg. This drug concentrates very well in the urine, and as such, it's used for uncomplicated UTIs only. It is not recommended for complicated UTIs or pyelonephritis. Nitrofurantoin is generally not recommended for UTI prophylaxis in the elderly. It is generally not appropriate for elderly long-term due to risk of pulmonary toxicity or pulmonary fibrosis, hepatotoxicity, and peripheral neuropathy. It also has a creatinine clearance cutoff of 60 mL per minute. It results in decreased efficacy, increased risk of acute lung problems, and peripheral neuropathy if used with impaired renal function. Some side effects to be aware of when counseling patients on this medication is that there is a risk of urine discoloration that may present as dark yellow or brown that patients may mistake for blood. They should also be monitoring for acute pneumonitis, which will present as cough, dyspnea, fever, or chills. The general treatment length for uncomplicated UTIs is 7 days. 3 days is not appropriate with this medication. To reiterate some points we made on the previous slide, some adverse effects that are common with nitrofurantoin include GI upset, urine discoloration, which will present as dark yellow or brown urine, which patients may mistake for blood in their urine, acute pneumonitis, which may present as cough, dyspnea, fever, or chills, and pulmonary fibrosis, which is usually associated with long-term use of nitrofurantoin. Peripheral neuropathy is also a very rare adverse effect that you might notice in patients. The primary uses of nitrofurantoin are in uncomplicated urinary tract infections, or cystitis. This drug should not be used for complicated urinary tract infections or pyelonephritis. Should also avoid use in patients with creatinine clearance less than 30 mL per minute, and should generally be avoided in the elderly, particularly long-term use, for the risk we stated above of acute pneumonitis developing in these patients. The Beers criteria states that the cutoff for nitrofurantoin is less than 30, and in patients greater than 65 it is okay to use. But you should generally be concerned with chronic use in patients with a creatinine clearance cutoff of less than 60 mL per minute due to increased rates of decreased efficacy and increased risk of acute lung problems and peripheral neuropathy, again, particularly associated with long-term use. The duration of treatment in uncomplicated UTI is 5 to 7 days. This medication should not be used for 3 days, as this would not adequately treat the patient. The next agent that we're going to talk about is clindamycin, or Cleocin. This agent is available both in oral and IV formulations, which makes it an attractive option for some providers as they are able to transition from IV to PO upon discharge. This drug adequately covers gram-positive, including community-acquired MRSA and strep. There is no gram-negative coverage with this agent, and there's also anaerobic coverage. However, this drug poses the biggest risk of Clostridium difficile colitis. As such, it is important to tell patients to report persistent diarrhea immediately so that they can be screened for C. difficile and be treated appropriately. The oral solution of this medication also smells and tastes terrible, resembling rotten egg smell. As such, it is important to prescribe the capsule when possible for the oral formulation. Because of its extensive gram-positive coverage, this agent may be used for community-acquired MRSA, skin and soft tissue infections, necrotizing fasciitis, and dental procedure prophylaxis. However, as I mentioned previously, it is best to use alternative agents whenever possible due to the highest risk of C. difficile colitis. The next agent we'll talk about is metronidazole, or Flagyl. This agent is also available in IV and oral formulations. As you can tell from the dosing, it's available anywhere in a range of BID to QID with equivalent IV and PO equivalents. BID dosing may be used with any indications except for parasitic infections, C. difficile colitis, and neurologic infections. Otherwise, it's generally appropriate to use TID or QID dosing. This agent is primarily added on for anaerobic coverage. And some things to be aware of is that patients should avoid alcohol during treatment and for 24 hours after the last dose due to a risk of what's called a disulfiram-like reaction with alcohol. This may result in shortness of breath, nausea, vomiting, increased heart rate, and headache. There's also a metallic taste associated with the medication. And similar to nitrofurantoin, there's also urine discoloration, which may cause the urine to turn reddish brown. And patients should be counseled on this possible effect so that they don't think there is blood in their urine. There's also a drug-drug interaction with warfarin, which may increase the patient's INR and place them at a higher bleed risk. Because it is primarily used for anaerobic coverage, it is indicated for C. difficile colitis, intra-abdominal infection, bacterial vaginosis, trichomoniasis, and H. pylori. The next agent we will discuss is vancomycin, which is also available in PO and IV formulations. This drug covers only gram-positive organisms, including MRSA, streptococcal organisms, and Enterococcus. The primary adverse drug effects are nephrotoxicity, or harm to the kidneys, and Redman syndrome, if infused too quickly. Redman syndrome is caused by vancomycin directly stimulating mast cells, resulting in histamine release, which causes symptoms of flushing, erythema, and pruritus, usually affecting the upper body, neck, and face more so than the lower body. Pains and muscle spasms may also occur in the back and chest, as well as dyspnea and hypotension. This may be avoided by slowing down the infusion, as well as pre-medicating with diphenhydramine. In terms of dosing this medication, doses are often patient-specific, and the doses will be monitored by obtaining trough levels or peak levels at steady state, depending on which dosing strategy is being used. I mentioned previously that it has both an oral and an IV formulation. However, there's very poor oral absorption for this medication. As such, the oral formulation is only used for C. difficile. It will not reach appropriate systemic concentrations to kill infections. This drug is also removed by hemodialysis at approximately 30 to 40% if patients are receiving a full dialysis session. As such, it should be dosed after hemodialysis sessions. It is important to note that while this drug covers MRSA, MSSA clearance is much better with beta-lactams. As such, it is best to de-escalate this medication as soon as possible to make sure you're using the most appropriate bactericidal medication to clear the patient's infection. The next agent we will discuss is Linezolid, or Zyvox, also available in oral and IV formulations, which are roughly equivalent. This drug is dosed twice a day, and similar to vancomycin, it only covers gram-positive organisms, including MRSA and strep, but unlike vancomycin, will cover vancomycin-resistant Enterococcus. Adverse effects associated with this medication include GI upset and headache, serotonin syndrome, as this is a weak MAOI, bone marrow suppression, which is associated with use of greater than 2 weeks, with thrombocytopenia being the primary effect you will notice in these patients, peripheral neuropathy, which is also time-dependent with use of greater than 4 weeks. Some of the use of this medication include resistant organisms, such as vancomycin-resistant Enterococcus, or MRSA if patients are unable to use agents such as vancomycin. An important note for this medication is that there is no dosage adjustment needed with decreased renal function, which is why you might use it for organisms such as MRSA or strep. It is also important to note this agent is fairly expensive, although there is a generic form available, so we try to limit its use as much as possible. The next agent we'll discuss is Daptomycin, or Cubicin. It has very similar coverage as Linezolid, covering only gram-positives, including MRSA, strep, and vanc-resistant Enterococcus. However, unlike Linezolid, it is only available IV and uses a weight-based dosing schedule. Adverse effects that you should be aware of include rhabdomyolysis, which may present as myopathy or muscle pain, primarily in large muscle groups, and there is an increased risk with statins. As such, it is important to monitor creatinine phosphokinase at baseline and weekly during therapy. only if you're going to be using long-term durations. Decrease use if the CPK becomes greater than 5 times the upper limit of normal and patients are symptomatic. If patients are not symptomatic, discontinue use if the CPK becomes greater than 10 times the upper limit of normal without symptoms. There's also the potential for a dose-dependent INR elevation. So for patients on warfarin, test the INR before doses. This drug is degraded in the GI tract, which is why it only has an IV formulation available. It is also important to note that this drug is an inactivated bipulmonary surfactant, meaning it is not appropriate for use in pneumonia. However, it may cause an adverse effect known as eosinophilic pneumonia, where there's a high eosinophilic count. It is a very rare adverse effect. However, as we see increased usage of daptomycin, this may more common. We've just presented you with a lot of information. So to sum up what we have covered both in this and in previous lectures, here's a table of antibiotics that cover MRSA. Please note that 50% of all Staph aureus isolates are MRSA. There's increasing resistance to vancomycin, so using some of these other agents may become necessary at some point in your treatment therapy.
One of the most difficult to treat gram-negative infections is Pseudomonas. And these are the medication classes that you'll commonly see covering Pseudomonas. The first is the extended spectrum penicillin, Zosyn, or piperacillin tazobactam. Some of the cephalosporins also cover Pseudomonas, notably cefepime and ceftazidime. Carbapenems will cover Pseudomonas except for ertapenem, so just remember that one is the exception. Monobactams also cover Pseudomonas, which is just aztreonam. Some of the fluoroquinolones will cover Pseudomonas, including ciprofloxacin and levofloxacin. And then finally, aminoglycosides. You'll notice here the only oral agent that covers Pseudomonas is going to be ciprofloxacin and levofloxacin. So if for some reason you have a culture that results with Pseudomonas and it's outpatient, then that would be what you would need to use to treat, as well as if the patient had Pseudomonas inpatient and we're using that as a step-down therapy to oral at discharge. Anaerobic bacteria are most commonly seen in GI tract infections. The medications covering anaerobic bacteria are Augmentin, Unicin, and Zosyn. With beta-lactamase inhibitors, it extends the penicillin spectrum out to anaerobic coverage. Carbapenems, clindamycin, and metronidazole have innate function. Cefoxitin and cefotetin are the only two cephalosporins that have anaerobic activity, and then moxifloxacin is the only fluoroquinolone that has anaerobic activity, but it does lose other activity like Pseudomonas. It's also important to note that only clindamycin, metronidazole, and moxifloxacin are available as oral agents, so if you have to treat outpatient, then those are what would be required. There are several new antibiotic agents that are used for multi-drug resistant infections. The first being Avicaz, which includes ceftazidime and avibactam. It came out in 2015 and it was approved for complicated urinary tract infections, intra-abdominal infections, and acute pyelonephritis. Avicaz and Zerbaxa, which is ceftolozane tazobactam, do cover Pseudomonas. Zerbaxa is indicated for urinary tract infections, intra-abdominal, and acute pyelonephritis as well. The other kind of odd man out on this slide is Vancomycin or Orbactive, and this is approved for the treatment of acute bacterial skin and skin surface infections that are caused by gram-positive bacteria, including MRSA. So it does extend to MRSA coverage. It has a super long half-life, and one dose will last about 10 days. So oftentimes that's all that's needed to treat the patient. Several other newer antibiotics to the market include Linezolid or Civextra, and it was approved for just bacterial skin and skin structure infections, although it can be used for some other indications. It's similar to Linezolid in the fact that it covers MRSA. It does have a little bit less incidence of myelosuppression. Dalbavancin or Dalvance is approved in 2014 for the treatment of acute bacterial skin and skin structure infections, and it's pretty similar to Vancomycin. Dalafloxacin is the newest fluoroquinolone on the market, and it's also approved for bacterial skin and skin structure infections and adds MRSA coverage to the other fluoroquinolones. Now we'll briefly transition to drug monitoring and follow-up and what you need to look for when initiating patients on these agents. One of the most important things to monitor is the side effects of each of these medications. Overall, most of the antibiotics can cause some kind of GI upset, so it's important to keep in mind. Penicillins, in general, may lead to seizures or neutropenia, although they're relatively well received, and GI upset is the most common thing you'll encounter. Ceftriaxone can lead to a biliary sludge formation and is contraindicated in children less than 1 month old. Macrolides can lead to a little more than normal GI upset and can also cause QT prolongation. The amount of QT prolongation is different within each medication in the drug class, so if you come across a patient with a prolonged QTC and cannot switch to another agent, then be sure to check the different amounts of each macrolide. Fluoroquinolones also cause QT prolongation, but can lead to photosensitivity and CNS side effects. It can also lead to tendon rupture, which is something to be wary of, especially in the elderly or the young. Aminoglycosides can cause ototoxicity and nephrotoxicity, one of the reasons why we generally save it for last line. Tetracyclines can lead to teeth discoloration and esophageal irritation. It's important to take that on a full glass of water and ensure that the patient doesn't lay down directly afterwards. Tigecycline has a little more than normal nausea and vomiting, so if patients are susceptible to that, then make sure that they are aware and have a backup plan on whether it be some kind of anti-emetic medication or anti-nausea medication to take with it. Bactrim and Septra can lead to Stevens-Johnson syndrome, which is a really big, bad anaphylactic reaction that is essentially similar to a burn across the patient's body. It can also cause bone marrow suppression and hyperkalemia, so make sure to monitor the patient's potassium closely if they have poor renal function or if they're taking other potassium increasing or containing items. Clindamycin is most well known for causing C. diff infections, so it's important with recent clindamycin exposure to be wary if the patient has any extra than normal diarrhea or stomach upset, to consider testing if it doesn't resolve. Metronidazole can lead to disulfiram-like reactions and metallic taste. So what that means is you'd like to encourage your patients to avoid alcohol when taking this medication, or they may have some severe emesis. Imipenem can also lead to seizures, so it's important to be wary of patients who have epilepsy. And Linezolid finally can lead to thrombocytopenia and serotonin syndrome. It's actually the similar structure to a monoamine oxidase inhibitor, so if the patient's on a lot of serotonergic agents like antidepressants, you'll want to make sure that that's monitored closely. When considering renal dose adjustments, it's easiest to memorize what isn't renally dose adjusted. You'll see here that nafcillin, oxacillin, and dicloxacillin are not renally dose adjusted, although they do have that reduction in renal function that we talked about in the beta-lactam PowerPoint. Ceftriaxone requires no dose adjustments, and neither does azithromycin, erythromycin, moxifloxacin, doxycycline, minocycline, tigecycline, clindamycin, metronidazole, and linezolid. One of the most important parts about drug monitoring and follow-up is to be able to recognize when you need to change your antibiotic therapy based on cultures. And that includes minimizing the length in treatment with broad-spectrum antibiotics. So if you can narrow, swapping to a more narrow targeted agent can be helpful for preventing antibiotic resistance, but also adverse effects. And then choosing the appropriate duration of therapy. Length of therapy also can negatively impact resistance and lead to increased adverse effects for the patient. Finally, the Sanford Guide is an incredible resource for all things antibiotics. It can tell you what bugs that each medication covers, standard dosing, durations of therapy, what resistance mechanisms are available with each bug, and is a general wealth of information when it comes to antibiotics. If you have a copy, feel free to bring it, and we can kind of walk through how to use it because it can be a little bit difficult at times. Thank you so much for listening and hope you have a great day.